everyone, and welcome to the Sex and Wellness Podcast with Dr. Mary Grimberg. Today, we're going to be talking all things perimenopause, and we have Dr. Andrea George here. She is board certified in endocrinology and obesity. She owns the first direct endocrine care clinic here in Austin, Texas. It's called Hill Country Endocrinology. Thank you so much for being here.
It is an absolute pleasure to be on your podcast today, Mary. And only we know what we have to do to make this day happen. So
just to give everybody a little background, it is now 12:50. We've been playing on our computer since 12. Every aspect of that could fail did fail. So we're here on Zoom. Hopefully the quality sounds good, but we were here fighting to get this information today.
It speaks on our character, both of ours, resilience and, just going at it. So here we are.
Yeah. Well, we'll dive in, and I like to just jump right in. Just go ahead and start talking. So if you want to explain to everybody what perimenopause is, because a lot of people have heard about menopause, but they're not as familiar with perimenopause. So if you could jump into that and explain.
So menopause is the time period right before menopause. And when I say right before menopause, it can last anywhere between 4 to 8 years. So 4 to 8 years before menopause, up to 10 years, where it's a time period where we can have symptoms that are similar to menopause due to the fluctuation of hormones in our body. So our ovaries that secrete hormones, it decreases slowly. And as we're starting to see that change in hormone functioning, we're starting to feel these symptoms. And that is the time before menopause that we call perimenopause.
Yes. And so how do you know you're in perimenopause versus it's stress versus thyroid issues? Because I feel like right around that same time, right? Like 40, 45, 50, we've got a ton of life changes happening too, right? Depending on when you had your kids, we have potentially empty nesters or kids in high school or no kids or a lot of life kind of situations. So how can you help somebody decide? I mean, I'm sure it's hard, right? Because they all mimic each other. So how do you do that?
So in order to answer this question, let's talk about a couple of the symptoms that patients can have. So a big one is their mood changes or irritability, increased anxiety. 40% of females talk about mood changes, vaginal dryness or frequent urinary tract infections, brain fog. They say, I feel like there's just this dark cloud over my head. Changes in menstrual cycle is a big one. So you'll see either they're getting heavier, longer, or lighter or shorter. So changes in menstrual cycle, hot flashes. We all know that hot flashes, heat intolerance. And a big one that I hear from my female patients is, I've changed nothing but the sudden weight. So, I've changed nothing in my lifestyle. My food hasn't changed. I work out the same. Nothing's really different, but sudden lifestyle change. So these are some of the symptoms. So it's really important, like you said, how do you know whether this is not a thyroid issue or whether this is not a fibroid or whether it's not just stress? It is difficult because perimenopause, unlike menopause, there are no labs that could be abnormal. So it's not a lab diagnosis. It's a clinical diagnosis. So ensuring you're with someone who can kind of go through, like a provider, a physician that can go through all of these symptoms in detail and rule out stressors as a cause, rule out thyroid as a cause, and other issues like fibroids as a cause is important. And like you said, the timing of these symptoms, it's really at the peak of our careers, right? As a female, peak of major life changes, whether it's divorce or kids going off to college or young kids, lack of sleep, taking care of aging parents. These are all big events that are happening right at the time of perimenopause. So having that clinician that can optimize, kind of pick through and treat whatever symptoms are required appropriately is really important.
And you say they can't really diagnose with labs. So if somebody is going to go on hormone therapy, how would they know which hormones to be on then? Would it be a fluctuation or, you know what I mean?
So the reason, let's go back to that question. So the reason you can't tell on labs is because you're not in menopause. So you still have some production from your ovaries or estrogen production. You still have hormone production. And so what we're not going to catch is that fluctuation or that slight change because it could look normal on lab results. You will still treat it the same. Well, there are different options for treatment, but you would treat it with the three main hormones, which are estrogen, progesterone, and testosterone in females. And again, based off of the symptoms. Now, if you're telling me the biggest complaint you have is vaginal dryness, maybe we will do, vaginal estrogen, because that could solve that problem. So it's really important to figure out what symptom is bothering the patient. And then based off of that symptom, you can decide how you're going to manage it or treat it.
Yeah, I mean, that makes sense because even when you're not in perimenopause, our levels, if we are menstruating, they're all over the place because each phase of our cycle, estrogen's going to be higher in certain periods and the other hormones down in other areas. And so it's that. And it's also like kind of what you're describing, all these other symptoms, but also just even thinking about any abnormal changes that you're experiencing that may not feel correlated, right? Like sometimes I've heard of people having like vestibular migraines or like all of a sudden kind of getting random headaches. And then they're going to like all these separate providers and getting like, you've got like the antidepressants and then you've got your gut symptoms, your constipated. So you're kind of getting treated all separately. And so I think this is one of the biggest reasons I wanted to talk to you is because they could be coming to somebody like yourself or somebody that it really understands menopause because that affects, there's those estrogen receptors in so many places of our body that can affect all of it. And so do you see that as well, where somebody's been through the gamut, seen them in people, and then they see you and they're like, oh, it's perimenopause.
Right. No, this happens all the time because, they make the patient feel like you're crazy. It's in your head, oh, you've gained weight. Okay, well, you should eat better. And these patients come to me and they're like, I eat so well. I'm doing all the right things. Look at it. And they're still gaining weight. So it's really important to find that physician that will take the time to hear the whole history. Now, don't get me wrong. Can some of it be optimized with lifestyle or stress management 100%? Because I don't believe the body is just one thing and it's a whole. But it's also important to understand that there is the changes in your hormones that need to be addressed. And if hormone replacement therapy is indicated, it should be offered to these patients to help them improve their quality of life.
Yeah, but it's crazy because it's like, where do they go? Because it's hard because, say if they don't have access to you or they're in some other state anywhere, because I think it's hard to even find access because sometimes people are just, it's the wild, from what I've seen, it's kind of the wild, wild west, it's like, who do you, and how do you know you're with the right doctor? You know what I mean?
Right. No, obviously I'm biased because I have a direct care practice. And so I have more time with my patients, right? I spend up to an hour during each visit. My patients have my number to text. And so it's a different level of care. But really finding, like I say, find a physician who will listen to you. And I have patients like that all the time that come to me with these non-specific symptoms. And even if it's not endocrine related, what I can always do for them is kind of come up with a plan and coordinate care for them. And that is outside of kind of my role as an endocrinologist, but it's important because patients do need coordination of care, or just to say, this sounds like this, maybe go to the specialist to see what they have to say. And so again, I know it's hard to find the right physician, provider, but definitely do your research. And there are good doctors out there, that are listening. And so you just have to find them.
Yeah, it's like any profession, right?
Yeah.
There's people therapists that, some of them say some crazy stuff and maybe don't practice according to like the standard of care. It's like any other profession. And so finding somebody that's willing to listen and then refer you out too if they don't know. I think that's important. I almost find like, because, we have similar practices. So do you want to explain what direct care is?
So essentially, the whole purpose of direct care practice is that we don't deal with insurances. And so we deal with the patient directly. And the relationship, the conversations are between the patient and the physician. So we're not dictated by the limitations of insurance practices. This is so helpful because our new consults are not just 20 minutes of just walking in and walking right out, right? It's an hour consult where we spend time, an hour to 90 minutes, just going through each and every one of their questions and concerns. So we come up with a plan. Patients have direct access to you by text messaging, and we have a smaller patient panel. Like an average endocrinologist can have anywhere between 2,000 to 2,500 patients. Direct care practice can have about 200 to 300 patients, so 10% of the patients. And so we just have more time to think about each patient care, to collaborate with other providers. Like when I have a question about a patient's care, I'm not waiting for, a note from the doctor. I'm picking up my phone, I'm calling them, the physical therapist, I'm chatting with them. What else can we do? And so we're really collaborating to improve the patient's overall outcome and not waiting another 6 months for the next follow-up visit to kind of talk about what happened now in the last 6 months. So that's just a little snippet of what direct care is.
Yeah. I mean, yours is kind of an ongoing as well, which I love. And also kind of same for our physical therapy practice, right? We're one-on-one, no insurance, but the quality of care, we're able to sit down and look at things outside the box and kind of put all these pieces together as well. So it's almost like, because if it's somebody's having all these symptoms, right, and they're coming to me and nothing's kind of adding up, I'm going to say, hey, have you considered talking to somebody like yourself about perimenopause? And unfortunately, a lot of people will say, what? Wait, because you think, oh, menopause, nobody talks about like the age of that, you know? You don't expect to have symptoms when you're that you turn 40 and you're like, wait, what? And so it's unfortunate that there's not as much information out there, but it does exist and it can be helpful. Were you going to say something?
Yeah. I mean, you kind of said, well, in their 40s, and you have to think about the dynamics of like a female nowadays, right? We're not having children until late 30s now. And so when you think about it, say you come in and you have a toddler, nobody's thinking about perimenopause. So like you just had a child. But we're now having children much later than we did 10, 15, 20 years ago. And so it's changing. Like what we need to look out for is different for our patients.
Yeah, because you can still be fertile during that time, right? Yeah. And you can still have kids. Mm-hmm. And it doesn't mean you can't. It just means you're in this phase of life that is fluctuating. And I remember one of the first times I worked with a patient that was in perimenopause, and, PT school, we didn't talk about it. A lot of the stuff I've learned with Con Ed and all that. But I remember her saying that, I was like, how's your weekend? She's like, it was okay. I went to the ER in the ambulance. And I was like, wait, what? What? Are you okay? And she's like, yeah, I thought I was having a heart attack and it actually ended up being a panic attack. And when they were putting me into the EMS, they were like, yeah, this happens all the time to women your age. It's perimenopause. And that's when she found out she was in perimenopause. Yeah. It was like, she felt like so dismissed, like, oh, just another woman in her 40s having a breakdown. And it's like, and you just expected to deal with it and not get treatment for it. So that's another big thing. Like to say, well, this is normal. Well, is it, there is quality of life improvement with treating or identifying and treating these patients. So we should be doing that. Yeah. It's all over the map, but okay. So let's go to can you explain the difference of bioidentical hormones to people versus hormone replacement therapy? Because I think people don't necessarily know the difference. Mm-hmm. And kind of. Okay, this question comes up all the time for my consults, right? As an endocrinologist, my answer is probably going to be different from the general hormone clinic that you will see around the corner. And I think this is an important topic. So I wanted to actually read out the statement from NAMS, which is the North American Menopause Society. This is where you should really get your information for perimenopause, menopause treatment. So
I highlighted this and I'm going to read this out, and then I'll explain a little bit more. But essentially the term bioidentical therapy, it can be misleading because there are both FDA approved and compounded bioidentical hormone therapies. So some people call it bioidentical, and they don't understand that even the FDA approved medicine can be considered bioidentical by word. But when layman terms of bioidentical, they're talking about the compounded medicine. So essentially the rest of the statement goes like this. Bioidentical hormones, including estradiol, estrone, methylprogesterone, which are regulated and monitored for purity and efficacy, are available in both FDA-approved medicine. And then compounded bioidentical hormone therapies are prepared by compounded pharmacies using providers' prescriptions, and these also have multiple hormones, including estradiol, estrone, estriol, DHEA, testosterone, progesterone. But they're unapproved combinations or formulations, and they're non-standardized, untested routes, such as pellets, which are, I think, my personal one that I stay away from. And so the purpose of this is compounded or bioidentical. That terminology is being used a lot, but both FDA approved are technically bioidentical. So rather than using bioidentical, it's compounded versus non-compounded, I think, or what's available is a better way to differentiate them. And the difference is when it comes to compounding medicine, we do have different formulations. Some people may not tolerate, so you can use them in different creams that we can use. But it's important to understand that there's no studies on these, and we no safety or efficacy studies on these. The only time compounding or bioidentical, I'm going to put quotes on that, should be considered is for testosterone for females, because there's no FDA-approved testosterone treatment for females. There's FDA-approved testosterone treatment for men, but not for women. And then, as you heard me say, I'm a very open-minded in my care for patients, and I don't have strong opinions on a lot of things, but pellets are
it is, you're so many people. It's a very heated topic.
And that's because I see the complications from them.
Oh, I've seen it too. Yeah.
All the time, extreme complications. And it's kind of unfair because these hormone clinics that throw these high doses of pellets into these patients, they have a complication and then they don't see them. They don't help them. And there's nothing you can do about it because it's in your system. There's no way to remove that pellet. So the only thing I always tell my patients is stay away from pellets. We could titrate everything else. We can, if we need to do compounded, that could be okay too. Stay away from pellets.
I think we need to describe, because I think we're assuming people know what compounded means. So let's kind of back up a little bit. So what you're essentially just said is essentially compounded versus non-compounded.
Right.
And the ones that are FDA approved. So there's a big issue because some of these hormones, like when they say bioidentical, it could be misleading. Mm-hmm. And that is kind of where the sales portion comes in, right? And so it's important that we do our research. And this is really why I want to talk about this, because it's really messed up. Like the fact that people can say these things, but then the people receiving them, the patients, aren't understanding this has not been FDA approved. Mm-hmm. And whether or not, whatever, after all the drama with COVID and all that stuff, it's more of, hey, this is like standardization of care and knowing what exactly is going in your body, because compounding can be different in one pharmacy versus another pharmacy. So they're good pharmacies, don't get me wrong, but it's more of, hey, it is up to the person compounding it. Mm-hmm. So the exact measurements, right? So it'd be like if you were baking a cake or something, right. The ingredients have to be like exactly that. Like, how are they measuring it? Who's doing it? Like, are they you know what I mean? So I think it's important for people to understand that too. And so versus the FDA approved, like what you're saying is it's been studied, it's measured, you know exactly what's going into your body.
Yeah. And honestly, majority of my patients that come to me, they've been I'm not their first stop. So they've been to a couple of places. And by the time they come to me and I explain the difference and I say, well, let's try the estrogen patch, they feel great on it.
Yeah.
So again, is it, like I said, is it a sales pitch? I mean, it is, because these are women that are feeling horrible and they're weak and they're not able to function like they used to, and they don't know what's wrong with them. So they're desperate to do anything to feel better, right?
Yep.
And that's where all these hormone clinics or providers that don't understand the guidelines or the terminologies are kind of preying on them.
Yep.
And selling them these things that are not necessary when there are FDA approved, well-studied hormone therapies available. Like I said, we don't have one for testosterone for females. And so, yes, there is a part that we don't know yet, not yet, but we do for estrogen and progesterone. And so the need for compounded medications is probably not really necessary for these patients.
Yeah.
I wanted to read specifically from the guidelines, because it's important not only to know that, to see somebody that knows what the guidelines are and that they're changing, and to understand the difference between these terminologies.
Well, yeah. And what we'll do is we'll add that website or the URL to that, because it's not just us saying stuff on a podcast. There's stuff on here when we're talking about medications and we're talking about hormones. I want people to have the standard of care.
Right.
And the North American Menopause Association or
Society.
And that's where we go, right? And so that's where we're going to look at. And on top of it, knowing what it is, like, is it compounded, non-compounded? How are they even measuring it? I've had somebody come in that was given compounded testosterone, and it was changing everything about their body. And they were unaware of even the genital changes, like the clitoris enlarging, random facial hair, acne, and this isn't, I've seen it a few times, and they were unaware of the changes that were happening in their body. And also I was like, hey, at least is there a baseline? I know that hormones can fluctuate, but I mean, you can tell if somebody's taking way, way, way too much testosterone too. Right. And then that goes to the study that, the Women's Health Initiative.
Oh yeah.
That scared the shit out of everyone. And it's just like, so now, do you want to describe a little bit about that? Because this is why people are scared of estrogen.
Yeah.
This study is why people are scared. And so you want to dive.
Yeah. So the Women's Health Initiative essentially is one of the biggest studies for hormone replacement therapy. I think it was about 160,000 females start long time ago, I think 2002, and then had multiple levels or layers for the study. But essentially, they came out with this alarming study that said, dangerous. Hormone replacement therapy is dangerous. Don't do it. It hit the medical world really hard, and everyone stopped, hormone replacement therapy. Since then, obviously, we've learned a lot more. The biggest scares were like heart disease and strokes and breast cancer, a lot of different scares. And so nobody was on it. And physicians were learning how to prescribe this because they're like, oh, it's dangerous. I'm not going to do it. I don't want the liability behind it. And then since then, there's been a lot of studies done that actually shows the benefits of hormone replacement therapy if done correctly, appropriately, good history, monitored. And so now we're really taking a turn, and the physicians that are learning and staying up to date are very comfortable with hormone replacement therapy. So now with the benefits, we're seeing there's obvious benefits, quality of life, improvement of osteoporosis, cognition, sleep, cardiovascular benefits. And so there are benefits when done appropriately.
Well, it's the same thing. It's like, I don't even know if people understand what estrogen does. Like, that helps you reduce osteoporosis, right? It helps your muscle mass. We have estrogen receptors on our brain and are all over our body, right? And when our estrogen is lower, it actually increases risk of cardiovascular disease as well. The irony, right, of that. And it's like, okay, it's any time you put anything in your body, it's a risk, right? And so everything in health is a cost benefit.
Right.
analysis, right? And so, the Women's Health Initiative, the biggest thing is it showed these people getting breast cancer, but they were taking hormones 10 years after menopause. And so those aren't even the people that, and so then there's that whole aspect. And then, so we've all been kind of trying to undo all of that fear. But the reality is, okay, well, if you're not taking estrogen, right? And again, some people may not be able to tolerate it. So
Right.
whatever people want, I just want them to have the info, right?
Yeah.
So hypothetically, say somebody that would normally be on estrogen because there's no risk for them, or they just want help, but they're not seeing the right people to put them on it. Well, you can become depressed.
Mhm.
You're exhausted. So then anxiety increases. So people tend to drink or be more sedentary, which increases what? Your risk of cancer anyway.
Yeah.
So it's like, what is your quality of life and what do you want it to be versus just like avoiding cancer? And I think that as a cancer survivor myself, I know that there's no guarantee, even regardless of what it is. And so it's all a cost benefit analysis. And so if you have a family history of, and all different breast cancers respond differently, right? There's ones that feed off of estrogen and some that don't. Yeah. So there's just so many things surrounding that. But just to know how good estrogen can be.
Yeah.
For us.
And I want to, because I love reading facts. And this again is from the guidelines. So attributable risk of breast cancer. The attributable risk of breast cancer in women, mean age of 63, randomized to estrogen plus the progesterone in the World Health Initiative, the Women's Health Initiative, is less than one additional case of breast cancer diagnosed per 1,000 users annually. So this is a risk slightly greater than that observed with one daily glass of wine and less than that with 2 daily glasses, and similar to the risk reported with obesity or low physical activity. Yeah. So what an important statement. Like, this is missed. It's not an increased risk that is so significant. It's similar or less than that of someone who's drinking 2 glasses of wine a day.
Yeah. It's the misinformation. And it's just so important that people know this stuff. And so I love that you're quoting exactly from their resource, because that's, those are the guidelines. But, I don't even know if people, before like the compounding, like people are just assuming that things are done right. And it's like, they're not. Like, I would love to go into life and just be like, oh, this person, they have their best intention helping me. Well, that person maybe, but they could also misread something. It's just, there's so many things that can be adjusted and,
Well, it's also patients' mistrust from the healthcare community. And so they haven't had the best exposures. But one thing I always tell my patients when they're worried about medications, I always tell them, remember, supplements and these kind of compounding pharmacies are multi-billion-dollar companies also, or industries. And so think about that and let that settle in. Ensure you have a good healthcare advocate, right? Someone who's going to be on your side to help you make the right decision for you. And I think that takes away most of the fear. And I've never had a patient say, I'm not going to do what you tell me to do, or, what you decide, because most of them by the end of our conversation feel very confident that I'm out there for their best interest.
Yeah. I mean, it's crazy because it's like, I don't truly believe most people have bad intentions. I think that there's a lot of fear, and when there's money involved, right? And so supplements can be helpful potentially, like you were saying, like with testosterone, potentially with the compounding there, but with the hormone replacement therapy. And the thing is, like, even if you don't know somebody that can advocate for you, because it's very hard to find.
Mm-hmm.
And if you find one, they all know each other. So like, stick in that group, because I only talk with people that I trust and like that I can, like, you know what I mean? There's, hey, you're a business owner, but that's not all you're doing. You're not looking at people like dollars are coming in.
Yeah.
But if you don't have access to that, the best way to know and to advocate is to read those resources, to not go in blind. Don't just blindly trust people. And I also see, and this is kind of a tangent, just like people just not willy-nilly, but more hysterectomies without like, why are you getting a hysterectomy? Like, you know, it's still like an area, like even when you remove it, you may not think you need it, but there's also hormones in there and it changes the structure in your pelvic cavity. It's just so much stuff. And then if you're going to have those things, I want people to know, hey, I did all this background research on it and I feel like I'm good to go. Do you get what I'm?
No, I mean, and I've had patients that had hysterectomies in their 30s and never offered hormone replacement therapy. And now they're in their like 60s with severe osteoporosis.
Mm-hmm.
And they're like, doc, like, do you think I could have prevented that? I'm like, I don't answer that question. And yes, because I mean, I don't know 100%, but gosh, like if we can prevent that fracture and that hip fracture for this patient, the quality of life question is huge.
Well, it's that hip fracture, as a physical therapist, it's like you fall, you break your hip, and even in your mid 60s, if there isn't a baseline of strength and function prior, it's a slippery slope to death. And you wouldn't think so just outside, like, oh, a hip fracture. It's like, no. We're talking a quality of life, a decline of strength, a decline of, you're not moving. And then all of a sudden, all these other things occur. So the fact that we want to prevent osteoporosis, right? So then you get the estrogen, and then on top of it, the lifestyle stuff, which we'll dive here in a second, is like strength training. And what I find, and maybe you've seen this too, is that most of the gyms that are strength training tend to market to men or people in their 20s. And when you're 30, 40, 50 plus, going to a gym like that can be A, either intimidating, or B, you cannot feel like you're being seen because they might treat differently, right? I have plenty of gym owner friends here that are great, right? And I prefer people too. But in general, like look at all of these big chains, they all really market to 20-year-olds, 20, 29 or whatever. And so let's dive into then even just kind of like, is there anything else, like try not to say like keep doing, but anything else hormone wise you wanted to add? I mean, I've touched on vaginal estrogen in a previous episode, so they can link back to understanding that a bit more. But anything else hormone wise you wanted to kind of touch on?
Remember, there are also non-hormonal options. That's important to know. There's Veoza, which is a non-hormonal medicine for hot flashes. There's Estrovera. Again, it's non-hormonal supplement that can be used. So there are non-hormonal options also.
So let's dive back to what are some non-hormonal options for managing perimenopause, including lifestyle.
Okay, so I find lifestyle to be really important, and I always tell my patients, like, do the hormone replacement therapy if that's what you want to do, but focus on lifestyle modification because this is a time we really need to prioritize ourselves. If you think about this age group, female patients, they're not prioritizing themselves at all. No. I do focus on this a lot. So let's talk about a couple of them. Smoking, it's a big one. It's, in patients who smoke, they're a couple of years earlier onset of menopause. So you want to talk about smoking cessation. Exercise, you kind of mentioned this, but strength training, muscle training is really important because as we age, we lose muscle. And so we really want to focus on strength training. I say this, and every time I say this, my patient looks at me about meditation and stress management. It's just so important to just shut down your brain because it's on the go all the time. Along with this is sleep hygiene. So, putting away your devices before you sleep, getting to bed on time, and having that routine set. I always talk about cooling devices, making sure your rooms are colder, suitable for your temperature, for your body, whether it's fans, the clothing that you wear to work, so you're comfortable throughout the day. That's another one. Sunlight in the morning. The importance of AM sunlight is something else that I always chat about. Decrease alcohol use. As we chatted about alcohol, increased alcohol can make your symptoms worse. Nutrition is another one to focus on. High protein, high fiber, decreasing refined sugars is like, those are really important. So lifestyle modification kind of sounds like just what we should be doing for ourselves anyways. but it really augments the process of overall wellness and health in this patients. And then a few things supplement-wise, vitamin D is a good one or an important one. And I always joke around. I'm like, although we have a lot of sunlight, no one's ever outside under the scorching heat. So vitamin D deficiency is huge in our patients. Magnesium, which can also help with some of the sleep concerns that you may have, and then omega-3. So these are 3 kind of supplements that you can consider along with the lifestyle changes.
Yeah. And I think that it's so much where people are like, well, for me, I didn't really understand what stress management meant until I went through a major health crisis.
Mhm.
And once you start recognizing what stress means, I think most people don't even recognize they're in a stressed environment. And so what I'll have people do is just say, hey, just notice your heart rate when you're hearing a difficult conversation or somebody's talking to you a certain way. Just observe it and they'll look at it. And sometimes people's minds are blown because they say, oh my gosh, I wasn't even a part of that, what was happening. And I was stressed out, right? And it's mind-blowing to start to teach people that. And then, so then what happens in understanding, well, if your cortisol increases because it thinks you're running from a bear, your blood sugar is going to spike, it's going to crash. And then that's when you're going to crave. That can increase anxiety. It can increase belly fat. It can increase exhaustion. And if you're doing that all day and then you're chugging caffeine and then you're not sleeping and, you're running around taking the kids everywhere, your body's going to hit this point where it's just like,
I always tell my patients, like, either we be intentional and make the changes now, or your body's going to shut down. I know that sounds harsh, but it is. It can't keep
It will make
going.
the decision.
It will
Yeah.
make the decision that it can't go. And that's our mental breakdown. And that's when you have these pains that you can't even get up in the morning. You can't sleep anymore because you've hit that wall now. So it's so important to do all of these things. And like you said, as physical therapist, muscle tension, right? That's another one. You see the muscle tension in your shoulders and your back. I mean, I personally had to deal with that through training, and I'm like, why do I always have shoulder and neck pain? It's because of years of, this horrible posture and not taking care of my body and not being aware of how my body, mind, heart, everything works together under stressful situations. And one of the things my patients say is, but I've been stressed all my life. I've dealt with this all my life. Why can't I handle it anymore? Now it's something small and I'm just breaking down because your body needs to reset. You need to focus on whole body, mind wellness. And again, I am an endocrinologist by training, but I firmly believe that it's everything. You have to focus on it all. And that sounds like a lot, but if this were anything else in our life, we would focus on it all. If it were for our kids, we would do it all, right? So why can't we translate or do the same for ourselves and our bodies and our minds?
We've been taught, be quiet,
Mhm.
do what everybody else tells you to do, and don't make a fuss, right? And so it's not a coincidence that we see so many people pleasers in women, right? And then add on women in, oh my gosh, like male dominated industries that are moms. It's just like compounding, right?
Yep.
And then you get to this point where you don't even know what non-stress is. That is your base.
Yeah.
And it might feel like, oh, this little thing just ticked me off. And I'm like, no. You're up here already. It takes this little thing for you to fly off the handle.
Right.
And I'm not here to judge. Like, I am not in menopause, I don't think, or perimenopause, but I could be. But my life change happened when I hit a wall when I had cancer. And that's when I had to make all these changes because my body could not go further. I try and then I'd be like, punch back down. It's just like every time. And I think one of even the biggest things is I didn't recognize how much that stress was wearing on me.
Oh, yeah.
You don't realize it until you know what good feels like.
Mm-hmm.
And there's a trust factor of just trusting that, hey, I get that this is a lot, but start small. Yeah. I just want you to notice. Once you start noticing the effects on the body, your body kind of makes a decision for you. You know what I mean? You're like, I feel like crap every time I eat like I love crumble cookies, don't get me wrong, or like a cookie, right? But it's like, if I do that multiple days in a row, I'm just like exhausted. And so I've learned, okay, if I'm going to do this, I can't compound it with all these other foods, right? But the decision's made for me because I don't want to feel like crap.
Right. No, and like I said, I'm not any better. Like, as a female physician, you're like, I was in fellowship when I had children, and then you're trying to deal with childcare aspect. You're still trying to be a physician, the patient care, and then now I'm a private practice owner. So there's just so many different things. But one of the things I have to remind myself, so it's an active effort, right? It's not going to be passive, especially if you're kind of like driven and always had to do a lot of things. It's an active effort to say, it's okay for your calendar to be empty. It's okay not to get something done. It's okay to sit there and just do nothing. And that sounds like, how can you, not do anything? There's so many things to do. We're always going to have a to-do list, but really to get it out of your mind and just to think, okay, today I'm just going to, and even like scheduling an appointment to get your nails done is an active effort. You're still like, I have to get to this appointment, and that's work. So just to say, I'm going to do nothing for an hour. I challenge you all to try that. It's so hard, but it's nice. Our body needs that rest. How come everything else in this world rests except for us and our bodies and our minds? So you'll see by doing that, you'll get improvement in overall quality of your life.
Yeah, totally. All of it, because you'll see things just starting to regulate. You'll feel yourself not being on edge. And if you feel like you're flying off the handle right now, it's because your nervous system is in overdrive. And we've normalized that, especially in the Northeast, like go, 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 go. It was one of the reasons I moved away from DC, is just that it was perpetuating this mentality that I already had. And, Austin is better, but it's still this culture that we have in the United States of go, go, go. And it just adds on like just all the hats in general that women are wearing. We're wearing more hats than we ever have. Yeah. And we're trying to juggle and do all these things that even subconsciously, when I'm on meetings, Zoom meetings or whatever, and it's just me and all men, my body tenses. I'm not going to lie. Like, I mean, I can look confident, but the reality is I'm stressed out. And not because they did anything wrong. It's not them. It's just this like, oh, okay, I have to perform at this level that maybe it's subconsciously is in my head. I have to like outperform because I'm a woman, right? And it's like, nobody's necessarily saying that, but that's just kind of like, sometimes it is said under, depending on what industry you're in. But the point is that recognizing that it's okay to slow down. And I'm not, like you're saying, it's not like going and get your nails done. It's more of like, an hour before bed yesterday, full transparency, I don't have kids, right? So it's easier for me to do some of this stuff, but I've had my own healthcare issues, which took up a lot of time. But just even yesterday, it was so nice outside and just sat there looking at the stars and just sitting there just for 20 minutes. I had nowhere to be. Yeah. And that is a gift, just to sit. And it's not saying do nothing all the time. It's just pull yourself into this present moment right now. Yeah. Reset, slow down, and take care of yourself and your body. Like, that's the most important thing. At the end of the day, you can go and try to attain all these goals, but if your body's not there, health-wise, mentally, physically, you're not going to be able to get to the end or, the finish line. And so slow down and just really take care of that body. Listen to your body. But even when you hypothetically say you make that finish line, you're not going to feel any happier. It's the process of slowing down and enjoying it. No, people, when you're, I don't know, I'm kind of morbid, right? Because I faced death with cancer. And so I'm like, okay, well, if in 10 years or 20 years or whatever, it's like, you don't see people on their deathbed saying like, man, I really wish I did extra laundry. Or I worked an extra day, right? Yeah. And so I know it sounds messed up to do that, but the reality is we're all going to die someday. And so our health should be number one priority. When, obviously there's things that can affect that with like all the things that people are going through midlife, right? Yeah. But understanding that even if it's just taking a few minutes or going on a bike ride or walk or whatever it is, just allowing your nervous system to know what that feels like, because then you'll start craving it more. And so the more you expose yourself to it, it kind of naturally takes its own course versus, oh my God, I've got to change all these things. I wouldn't start at trying to change everything, because it's the reality is you're not going to sustain it. I mean, I'm not going to sit there and say, hey, you have to do all these things. Yeah, there are certain things I get stressed out about. And then I'm like, okay, how do I bring my nervous system down and whatnot? But nervous system regulation is kind of what we're bouncing around, but that's essentially what it is.
For sure. And like you said, I think most of my patients, even weight loss patients, they struggle when you give them 15 tasks, right? And like, do this, this, and this. So I never do that. I'm like, let's implement 5 minutes of strength training. 5 minutes doesn't seem hard, right? But actually consistency, even with 5 minutes, is a really hard task. But you start there. And then like a month or 2 months later, if you're doing that, let's add some, a protein goal to your list, right? And then a couple of months later, let's add some fiber goals. So slowly you could implement a new habit into your life, and you can pick and choose what you want to focus on. And you're going to see what makes you feel better and what doesn't. But it's just the overall wellness of your body is really important in this perimenopausal phase. Like we already discussed, you are going through the time of your life is a very complicated time of your life. So anything and everything can just help and optimize that for you.
Yeah. And that kind of ties in a bit, which we haven't necessarily discussed yet, on how insulin resistance occurs in perimenopause, which can be contributing to the weight gain and stuff. Can you describe a little bit about that and then how stress affects that?
Yeah. So insulin resistance essentially is insulin produced by our body that is not working the way it should be. So insulin's role is primarily to bring glucose into our body. So we have insulin that is not doing that. So the more it produces more insulin for these blood sugar rises, and as a result, it's just not working. And insulin in and of itself causes weight gain. And so it's just this, so you get weight gain, which causes more insulin secretion, which doesn't work as much. And, just this downhill cycle of bad things happening. And same thing with the stress hormone, it increases your blood sugar. So blood sugar does the same, with the insulin increasing. Insulin resistance mainly occurs with weight gain at this age. And then that weight gain becomes the weight that is gained becomes harder to lose. Okay. And so that's why it's important to do all the nutrition and the strength training, because that's going to help with the insulin resistance a lot. And then on top of that, if you have a family history, you got gestational diabetes, those all can make things worse. And genetic predisposition. So like certain ethnicities have higher risk of diabetes or prediabetes. And so again, very important, the whole wellness part, what you're eating, what you're putting into your body. And again, it's not eat salads all day, every day, right? It's about the balance, the mindful eating, right?
Yeah.
And, still enjoy. I always tell my patients, I'm not trying to take the joy out of your life. And if that is food, I'm not trying to take the joy out of your life. But being able to do everything in moderation and supplementing or coming up with interesting recipes that still are fun to eat.
That's it. Yeah. But it's understanding what you're eating too. It's not like, hey, cut everything out. It's more about, okay, well, hey, if you're craving XYZ, right? Say if you're craving bread. Well, okay, there's certain breads that break down slower, right? So multi-grain breads or sometimes sourdough breads, choosing things strategically that can help as well. So that portion, but also if you're not regulating your stress levels, that blood sugar spike can limit people from losing weight as well, which can feed into the insulin resistance. And so that's why all of this is important during that age, because, in your 20s, somebody told me the other day, they're like, weight loss in your 20s is like one big fart away. And I was like, yeah.
It's true. I mean, that's what every single thing. Like 10 years ago, when I wanted to lose 5 pounds, I was able to do it. I'm like, yeah, just wait till 10 more years, right? Like it slows down every decade. Like, in your 20s, it was 2 days. In your 30s, it was 2 weeks. In your 40s, it's going to be 2 years. Like, it continues to get harder. But implementing all of these things into your daily life, or as many as you can, I think will really help improve the quality of your life.
Yeah, no, I agree. And then even just kind of the physiology of building muscle, that will help with stimulate bone growth. But on top of it, that can help with glucose absorption as well, correct?
Yeah.
Yeah.
And I mean, we can go talk about muscle in and of itself, but even as you get older, it increases your lifespan, right? Like your ability to walk, your ability to do things. Like muscle strength training is just so important. And so this is a really important question. Like some people say, yeah, like I run 2 miles every day, 7 days a week. Perfect. That's beautiful. Now let's change that. That's right. Let's add a couple of days of strength training because cardio is great. I'm not here to say cardio is bad for you. Cardio is great. It's necessary. We need it, but we need to add strength training to that too.
Yeah. And it doesn't even have to be anything crazy. I know that sometimes it's hard for people to know where to even start.
Right.
But, we teach a lot of weight training in our clinic too, because people are like, I want to do it, but I don't know where to go or here, or maybe, just feeling comfortable is a big thing, right? Because if you don't know how to weight lift and you're a woman in your mid-40s going to the gym, it's really intimidating. Yeah. I feel intimidated sometimes going to the gym, and I've been going to the gym since I've been lifting weights since I was 12, which sounds insane, but it's I just always liked it. I was an athlete and it was just something I enjoyed, but it's been a part of my life and it's still uncomfortable at times, depending on where you go. Right. Yeah. And so there's that aspect, but it can be something as simple as when you're practicing getting up and down off the ground, that can be starting as some strength training, functional things that you're doing. If you're I hate weight training, well, think about stuff you're doing around the house that's hard for you right now, and then just repeat that over, Well,
that's a good tip. Yeah, no, for sure. And I mean, for the same reason, I've collaborated with a local gym here for my patients.
Great.
And essentially, they know what kind of patients I have. A lot of patients that are, weight loss, perimenopause. And I've collaborated with them, gotten a good price for my patients to start going to the gym and just saying, hey, this is part of what we're going to do together, And then I have our InBody, which looks at your, body composition, which is also great, which is important because they can see, okay, well, this is my muscle, this is my body fat mass, and this is what I need to decrease, and this is what I need to increase. So more than just stepping on a scale. Again, there's just so many things that, when it comes to muscle training that can help with being motivated and finding the right team for you, to help you through that process.
Yeah, it can be challenging, but I mean, even just kind of talking about the muscle, I think that there's this big misconception, especially if you grew up in the 90s, right? Weight training wasn't as big as it is now. Women love, you go on social media, everyone's weight training, you've got this thing, everybody wants an ass, and they're just posting it and weight training, right? But those are the girls in their 20s, and it's I'm all about it. I'm just excited that it's cool now, but there's a fear that you're gonna bulk up so much that you're gonna bust through your clothes, and it's that's not gonna happen. If you see that, sometimes people are taking testosterone. Sometimes they're lifting really, really, really heavy weights, or maybe it's just kind of their frequency or whatever it is. So you may actually gain some weight, which it's hard to see because I'm in this phase of oh, I gained weight, but also my muscle is higher.
Right.
And so there's that whole aspect too of just this fear of becoming the Hulk for some reason.
Right. But and that's why body composition is so important, because you'll notice that your fat mass is going down. And so, and visceral fat specifically. And the scale doesn't give us the whole picture. I mean, we're going from perimenopause to kind of obesity management. We could talk about everything here today because thyroid, but they're all related, right?
Yeah.
And the scale is not the final answer to everything, because there are people that, their scale number is much higher and their BMI is high, but in reality, they're extremely fit and it's all muscle. So it's, again, really important to understand the person rather than just numbers.
I hate the BMI. I hate it. It has always told me I'm obese. Always. And it's just like, that actually triggered, that's a whole nother thing. That triggered a lot of eating disorder issues for me. Just like seeing that, because they were telling me to lose weight when I'm like 15. I'm like, dude, I'm like 135, 5'9".
Yeah.
Like eating around the clock and I'm all muscle.
Yeah.
Or maybe I was I don't remember the exact weight, but the point is that like, it's also working on undoing a lot of like the factors around having our body look this certain way. And every time you turn a corner, it's like Botox, fat loss, good bikini for the summer, this. And I know it and I still get sucked in.
Yeah.
And I feel sad about myself. And then I'm like, why can't I fit in these clothes that this person, you know? And so that also comes into play too. But overall, I love how you are just incorporating all of it, because if we all did kind of what you and I are doing, you know, you're able to manage it from a whole other perspective, right? With adding medication and management and all this stuff. A lot of my stuff is lifestyle, right? And physical strength and overcoming injuries and pain. But just imagine where our healthcare system would be.
Oh, yeah. No, I mean, and you kind of talked about this right now, but just the stigma and the size and all that. In my weight loss program, we don't ever come up with a goal weight. My goal that I have all my patients always talk about is like, what is your goal at the end? And it's generally what I try to make them come up with is health and quality of life. Like, to be able to move better with my grandchildren, you know, because to be able to wake up and feel well rested, their obstructive sleep apnea, to be able to walk longer or enjoy like a hike, you know, losing weight and that effect on their knee. So I always try to come up with a goal that is not related to the scale, because I think those are the goals that we're going to appreciate more and long. The scale is going to change from day to day. And that's not what I'm trying to attain. Don't get me wrong, we're still working on weight loss, but I restructure our goals for weight loss. And I think those are the ones that kind of take you further, you know?
No, exactly. They're lifestyle changes, right? Like how I have seen so many people and patients, and including myself, and just kind of getting caught in this like diet yo-yo cycle. And then you feel bad about yourself. It's a shame spiral. Then you don't want to go out and this and this and this and this. And it's like, okay, well, we're looking at it all from a perspective of insecurity and fear. Or, you know, we have a huge societal fear around fat phobia.
Right.
And it's like, if you know, don't weigh a certain, or you're not a certain size or whatever it is, it's like, either way, none of that's going to sustain long term, right? You'll eventually get to the point where you're like, I don't care. Like, if I can be 10 sizes smaller, like I'm hungry, you know, I'd rather be fat and happy, you know, you get to a point where you're just like.
And also important to know that obesity is a disease.
Mm-hmm.
Just like diabetes is a chronic disease, cancer is a disease, obesity is a disease. And so I always like to say those words, because even as a medical society, or like providers, physicians, we do a horrible job with how we treat patients who suffer with obesity as a disease.
Shame them.
Right. But it happens, let's be honest. And it's these patients that come to me in tears because they've been made to feel like they're eating McDonald's every day, or they're just sitting on their couch every day, and they're not. So to understand that obesity is a disease and it requires treatment like we would treat any other disease process. And there's no stigma behind it. There's no judgment. It is a disease process. And so again, finding the right physician who understands these things is so important.
Mm-hmm. Yeah. It's going based on how you feel, and not, you know, because there's a whole thing too where just even in the diet and world is just focusing on, like outcomes that feel good for you, like lifestyle wise, versus like shame never works, right? Shame and assuming that somebody's in a larger body that they're not exercising is a load of crap. And it makes me so mad because I've had plenty of patients, plenty of friends in tears.
Yeah.
You know, and I've even had friends that had cancer and they were like, oh, you have cancer because you're fat. And it's like, I can't, I can't even, like, how dare you say that? And you're just assuming that because you're in a bigger body that they're not trying. And it's like, you know, that's not true. Life is hard. Resources are restricted. We don't have access to information. Like, if people are treated kind of the way you're describing, it's like, okay, you feel like you have an advocate, not somebody being like, don't eat that.
Yeah. You know, like I tell my patients, I'm like, we're going to work together. We're partners in your health. There are going to be times I'm going to say, don't do that. But you want me to. You want me to give you that warning, because if I did it, then I'm not here to, you know, help you. But at the end, you're going to make your decision. We're adults here. I have 2 kids at home. I'm not making decisions for anybody else. You're going to make that final decision, right? You can't force anybody to do anything. They're going to go home, do whatever they want to do. So if they feel that, or you can come up with a plan that works for the both of you, that's ideal.
Yeah.
I don't know how we got into obesity medicine, but here we are.
Well, it's intertwined, right? Weight gain during menopause is one of the biggest complaints that I hear, and people don't understand why, because running and these high intense level exercises are not working, and it's because that you're not recovering fast enough, you're not getting your sleep, so your body's staying in fight or flight. That stuff works in your 20s. It does not work as you age, and so either way, as much as it sucks right now, it will help you live a healthier and happier life. And even if you're not even in perimenopause or you've dealt with chronic illness, this is stuff we should all be working on, but we don't have access to even know what that even means. But yeah, I feel like we could go on and on.
I know. We're both on the same page here. I agree. And you know what's funny is, I don't feel like I've been advocating for my patients just in my direct care practice. This is who I've always been. But I realized I could do it better in my direct, because when I have more time, less patients, I can do this better. And it's exactly probably why you're doing what you're doing, because you can spend more time with your patients. And
they're like, you're the one person that sees it all. Because I have time, right? And then usually I'm coordinating with their doctors anyway. And so I tend to be, you know, I can't manage medications or anything, but, you know, I'm like, oh, go see somebody like yourself, you know, or here's information. And then I just put it all out and I'm like, hey, it's your body and I'm never going to shame you, because there's a whole nother level of shame in cancer treatment, which don't even get me started on that. And so you have to decide what works best for your body, because a lot of times people are working on fear, like called CYA, like cover your ass, right? And so if these are the standards of care, you need to do these or don't see me again. And it's like, well, I keep saying this, it's, you know, evidence-based care is the patient, the provider, and research. And so we need to be talking about all three and addressing it kind of from that perspective, because it is ultimately that person's decision to come up with it. And then if they choose something that maybe you wouldn't have yourself, I gave them all the info. That's not my decision to make.
Exactly. And that's our role, right? Our role isn't, like I said, we're not making decisions for them. That's not how medicine should be. Our role is to collaborate with them, educate them, help them come to the right decision that they want to choose. Because there's so many factors that play a role, like cultural differences, their personal traumas. There's just so many things that go into why patients, you know, do what they do. Like I had a patient who came into me, I mean, this quick story, but I have a million other stories. But this one specifically, she came in, a lot of trauma related to her weight, right? And we talked about it. We started on weight loss medicine and it didn't work for her. Okay. And my practice is cash pay. Obviously, I'd want her to stay in my practice, but I brought her in one day and I said, listen, you've done it all. You've tried it all. This has been a years of journey. We've tried the weight loss medicine. It's not working for you. I'm going to say something that's going to be really harsh for you and you might not like it, but I'm going to suggest this. And I said, I really think we should try weight loss surgery. She sat there and she actually cried and said, I'm so glad you're saying this. I'm glad you're actually giving me the option to do surgery and not making it sound like, I didn't do anything or I didn't try or it's all my fault. Because she's like, if I went somewhere else, they would have been like, well, you may be not eating right on the weight loss medicine. And I was like, no, it's just not working for you. And
Yeah.
she had the courage to go and then get surgery and like actually just called me last week, and she's not a member of my practice. And she's like, I just want to thank you because you've been encouraging, you were the only one who encouraged me to go get this surgery done. And she wanted my business card. She's like, I'm going to go hand it out to everyone. I'm like, you're going to heal from your surgery. She's still in the hospital, by the way, when she called me.
Oh,
and I'm like, just heal from the surgery and feel better. But just to say, what was the right thing for her? It wasn't medicine. It wasn't my program, but it was surgery. And for her to accept that it's okay, that is still an option. And that's what you need for your disease. And she was so willing, so open, but she's been dealing with this for years and nobody had even offered that or suggested that to her. So just how you approach healthcare is so important with these.
Well, and approaching it, I'm a business owner, and unfortunately what I've seen as I've grown my practice and people that I've met over the years is they have good intentions at first, and then once money starts becoming involved, I don't even recognize them anymore. Yeah. And, those relationships fall off, and because I just don't believe in that. I believe it's a business, right? But I also believe that, hey, if my services aren't going to benefit you, I'm going to tell you. And our staff, we have this conversation. It's like, hey, if you think somebody's not going to benefit, like, that's okay. I'm going to refer you to somebody else. Or you're really tight on cash and you can only do one of two therapies. And I really think you need psychotherapy. I'm going to say, do psychotherapy first. Circle around with me. I'd rather use your resources towards that, because what you're telling me sounds more of you kind of understanding what's going on and why that's being triggered. And then we can apply that in the PT from the PT aspect. And so and it's exactly like what you said. You even did the same for me. Like I consulted with you because I'm like, hey, I deal with chronic fatigue and you're like, and, I explained all my stuff and you're like, hey, I actually don't think you're a fit because of XYZ, right? And I was like, oh, cool. Like, I mean, it just was refreshing to like talk to somebody and be like, not, talked into buying 5 million supplements. And
I know. And I'm very honest about this. And I joke around. I'm like, I might be horrible at business, but at the end of the day, but at the end of the day, honestly, for me, I need to be able to sleep at night. And for me, that means I did the right thing for my patients. And it's same. I am cash pay for the fact that I can provide more quality care, but not because I'm trying to make more money off of it. I could probably make more money going to a big system here, but that's not my goal. It's to give me flexibility, autonomy over how I can practice medicine. But no, it's if the patient isn't going to find, like you said, care they deserve from me, they need to go somewhere where they can, because this is a life. This is a human being, and it's affecting their ability to live the quality life. They deserve the best they can get,
Yeah, no, totally. I think that's partially why, the biggest thing for me is I've been there. Yeah. I've been gaslit over and over and over the years, and finally have gotten answers. And I know what it's like to be on the other side. Yeah. And I really empathize and then I get almost excited because I have resources that they didn't even know existed. Right. And I'm like, oh, all this money that I've spent on my own health and my PT education, which is probably well over $200,000 plus, right? And I'm like, here, I have all this stuff that I want to give you. Yeah. So
for sure.
Well, sorry, I didn't mean to cut you off. Were you going to say something?
No. Yeah.
I'm just looking at the timer. Well, thank you so much. This was an amazing conversation. And I'm going to tag your info in the show notes so people can have access to your care. And it just doesn't even mean that they need to be in Austin, right? Right. Just in the state of Texas.
Yeah.
So great. Well, thank you so much for coming. I feel like we could talk about this for a million hours.
We probably can, but I'm glad we made it work today. And always a pleasure chatting with you.
All right. Well, we'll talk soon.
Alrighty. Bye.